So, morning, Laura. Delighted to be having a conversation with you today about your role as a GP in Aberdeen City. Um, Obviously, you're working from home, I'm working from home. I'll just share with you that I have not quite worked out how best to handle my two old dogs. So the door's open and people might see Ollie and Max going back and forth, because if I shut the door, they just bark. And there's also an electrician in the house. So who knows what will happen? I don't know if you've got anything going on in your house.
There's always a
Laura,
dog they bark.
all right, brilliant. Laura, I'm just really keen to meet with colleagues across health and care to help people have some of the opportunities that I have in being able to speak to loads of different people, to recognise and understand the critical role that everybody plays, whether they're delivering direct care, as you will be, or whether it's support services. And I think giving people an insight into the lives of others always generates a different level of respect and consideration. So, as I've said in the introduction, you're a GP in Aberdeen City, but I believe you wear some other hats. So it'd be great to share with us what motivated you to become a GP, and just explain a bit about the different roles that you have.
Yeah, of course. So I trained in Aberdeen, so I'm an Aberdeen graduate, and I have to confess that when I was a medical student, I said that I wouldn't be one of these people who never left, and there was no way I was going to become a GP. So actually the thing I learned was that really I'm not very good at career planning. So I did my F1 and F2 jobs here, and I started in medicine for the elderly, as it was at that point, and literally worked my way down the age spectrum. So I then went to general medicine, and then I had some pediatrics, and then I went to obstetrics. And effectively, I worked with all groups of patients and realized that there wasn't any one particular disease or any one particular group of patients that I wanted to deal with more. I wanted a bit of everything. And so general practice provided that. I had some brilliant GP attachments as a student, mostly rural. And, so I had some really good role models as I was training, but it wasn't until I really actually got working with patients and seeing some of the clinical things that I really decided that general practice was going to be the one that ticked all the boxes for me. I have to say I loved hospital medicine, so it wasn't easy, because I like the banter of the doctor's room and the chat you get as you're walking down the corridors. And general practice, the banter is different. You're with the same team and you get to know each other really well, but you haven't quite got the same ability just to bump into people in the canteen and stuff. So I've been a GP, fully qualified now, for the last 7-8 years, working in the city centre. And then obviously a couple of years ago, this thing COVID hit, and there was a call out for COVID clinicians. And we have been running something called the COVID Hub, which I think most people have probably heard about now. Effectively, we're the team who help look after the patients who phoned 111 with symptoms of COVID. So it's not always just COVID, it's symptoms of COVID. And as we all know, those can be vague and many. And so we've been helping these people as a team, and admitting as required and looking after people in the community as required. We've done this alongside an amazing team of nurses out in the communities. We've got amazing nurses out, a team in the city, a team in Aberdeenshire, and a team up in Murray, because this has been an NHS Grampian service. We've been working remotely as clinicians, so we've been working from home, and that has had its challenges. It's had its benefits. An elasticated waistband, because you're sitting, is something I'm going to find it really difficult to go back from when we all do head back to the office full time. We've been able to provide an NHS Grampian-wide service with as few people as required, because we've been able to do it remotely, supported by these community nurses. So that's been a role that I've had, both as a clinician, and then over the last year I've been the clinical lead for that. So that's added a layer of responsibility and just looking after the team. So I took that on from some amazing other people who'd been doing the role before me, and we've literally just in the last month sort of gone to I hate to use the word because it's very topical, but that blended approach where we have transferred some of the care back to GPs in the community rather than having a disease specific hub. So there's been quite a bit of work to put together sort of an educational package for GPs who haven't necessarily had the same experience working with patients with COVID, and so that's been challenging, but actually quite a challenge I've quite enjoyed. Actually, it's something I think we've needed to do well, and hopefully people feel we have done. And we're just monitoring as things go. And the other thing I've learned, along with I'm not very good at career planning, is that I should never make predictions about COVID, because pretty much every time I do, something goes wrong, or the numbers climb or something. So I need to have a discussion with Corey and her team who do all the modelling, and say that I should probably be, part of that, because every time I open my mouth to make a prediction, it's wrong. So genuinely, I've got this wonderful slide of, here are all the peaks, and here's literally the meeting where I said, do you think we should think about changing how we do things? And then like 10 days later. The other hat I wear, just because that's not enough, is that I work for the university. So I'm one of the GP teaching team, and help with the year 4-5, so the senior medical students and the curriculum that they have, and supporting our practices, because I think that's the other thing, is that it's very easy to forget that throughout all of this, we have actually had students, and we need to keep them being educated, because there are future generations of doctors. We need F1s, don't we, come August? And so there's been people, in the background beavering away, trying to make sure that they have as much access to education to be able to work efficiently and safely. So that's also just been a really interesting strand of things. And to be honest, practice life hasn't exactly been quiet. So there've been lots of challenges just in the sort of main role that I have as a GP. So it's been an interesting little while.
Gosh, you certainly have your hands full, and we'll go on a little bit to talk about the changes during COVID, even just in general practice as opposed to in your COVID hub role. But interesting to hear about, at the beginning, you were talking about you as a medical student, and then the importance of how our, I suppose all of our undergraduates experience their education, in particular their clinical placements within that just now, because as you intimated in the first bit, that it's such a huge influencing factor in what you decide to do and where you decide to work. So yeah, I couldn't agree more, and actually really thoughtful of the experiences of students of all disciplines, and for our medical colleagues and our newly graduated other health and care professionals, just how they've experienced coming into Grampian, and really pleased with the support that they've got from universities and from our practitioners. And I'm not going to comment on the banter, but other than to say it is really, really important.
It's really important, yeah.
Oh, it's what makes the day, isn't it? And I don't think that's different no matter what job you do. Just one thing, because I met with you and your colleagues from the COVID hub, I think it was last year. Last year. And everybody was doing that from a voluntary perspective on top of the day job. Is that right? That's how that worked?
Yeah, and that's how it's continued. So, I mean, I think we have been a relatively covert little army, I like to think, because it's an eclectic mix. So we're GPs and nurse practitioners, so we're COVID clinicians, and we've got people who have remained away from retirement, and I think they've thought, oh yeah, it's just another month, and sort of 2 and a bit years or 2 years down the line, I think we're finally going to be able to say you can retire. We've got the majority of people are a bit like me, and they wear more than one hat, so they're doing this over and above, and they've been doing this over and above, including sort of out of hours, covering the public holidays, and we were a 24/7 service until probably March last year, I think, and then we've been working really closely with GMed, and I think GMed are the other service who people often forget about, that they're there overnight, at the weekends, public holidays, answering these 111 calls, and a lot of them are also wearing more than one hat, and I think it's been quite a privilege to work alongside a lot of these clinicians. There's been a huge amount to learn. We've, as a team, had the same challenges that all teams have had. You know, we've had people leaving, people moving away, we've had some babies, we've had some weddings, we've had, you know, we've had it all as a team. And I think, you know, when you're thrown together in fairly extreme circumstances, you get beyond the sort of idle chit chat and onto the important bits as a team pretty quickly. And it's actually, I think people think working from home, oh, you know, you're sitting there, and, you know, I joke about the elasticated waistband, but, you know, I've done lectures and tutorials for people about remote consulting and working from home, and just that it is your home, and that barrier between clinical work and, you know, being in your sitting room. You know, we're talking about the dogs barking and things. It has challenges, I think, for the clinicians. If you're sitting and you've got a palliative scenario and this is your safe space because it's your home, and suddenly you're dealing with really complex emotional situations and you're trying to do the best for your patient, that needs a bit of debrief at the end of a shift often, and just a little bit of decompression for people, because you don't have a commute, you don't have a coffee room where you can go and have that banter, you don't have that space in a way that I think you take for granted a little bit when you're at work, because you've never really had it. And I think that's just been quite a learning process for me, of just actually, I need to switch my work brain on now. I'm speaking to patients. This is, you know, they may be really unwell and I need to be thinking about this. I'm not thinking about this other thing, and just learning to literally shut the door on what's happening. But that's quite a learning process for people, I think, at home. And I think it's easy for people to not realize that. I think folk are like, oh yeah, you can work from home, you know, you've got a positive swab, but you're well, work from home. It's like, well, actually, how do we support you working from home doing that? How do we, as a sort of the leaders of teams, how do we make sure that we're recognizing this person is there? And you're quite isolated without people really recognizing that at times, I think.
Laura, that's genuinely a really thought-provoking insight into home working, and you've kind of moved us on to the next question, just around COVID has highlighted some of the best things. You've spoken about them, how people have rallied round, the importance of teams, the dedication of our health and care workforce, the support from the public at times, and but it's also shown up, I think, some real cracks and some real vulnerabilities. From your perspective as a GP, what have you observed? What have been the things? And we'll go on a bit to talk about what you think the future needs to look like. But what have been the things that you think have been positively nudged forward, and what are the things that actually, and I think you've just described one of them, the isolation and having to deliver care in a very different way. So the best and the worst things that you've observed as a GP.
So I think the best thing genuinely has been the way that, I think on the whole, that primary secondary care interface has been broken down a bit. I confess, I think the barriers are building again, but certainly at the beginning of the pandemic, you know, it just felt like we really were able to, we were fighting this together. And, you know, just the lines of communication seemed easier. I mean, from a COVID point of view, we had the wonderful, and whoever developed this acronym of the CIA, so the COVID Initial Assessment, I mean, that whoever that was, it was genius, because genuinely for me, and I'm quite childish, to be able to say I'm just phoning the CIA, you know, was just brilliant. But actually just the ease of being able to speak to people and making sort of sensible management plans, and trying to make sure that we got the right people to the right place at the right time, and you know, I'm all for protocol and making sure that things are done appropriately and as safely, but there was just something about the actual, it felt like a really cohesive system. And I think as time has gone on and as people have become more tired and time poor, and you know, we're all just a bit fed up, I think. And I think that's everyone. I don't think that's just healthcare workers and NHS grumpy employees. I think, you know, that's the public. That's, you know, we're all, as human beings, just a bit fed up now, aren't we? And I think as people get fed up, barriers go up naturally, because you're exhausted and you just can't cope with more change. And I think as that's just been, I think that's it was so wonderful. And it's just really becoming a bit more apparent that that sort of tide is potentially changing a wee bit. And I think that's just capacity. I don't think, I know, having trained and worked here, I know lots of the people, lots of the consultants or the registrars who I was training with. And, so I know it's not about individuals at all. It's the system pressure. And it's just actually how can we keep it as efficient for everybody as possible, and how do we help patients get through the system? Because I think actually for patients it's become quite complicated, and and I think the clap for carers thing was always a little bit awkward anyway, wasn't it? So that was always going to, the tide of that sort of positive wave was always going to turn, because who can maintain that for 2 years? But I think in general practice we have been unfairly vilified by the media. And I know everyone says, oh, don't look at the comments on Facebook, but it's pretty hard not to, and they can be really quite nasty. And at the end of the day, when you've spent time, what feels like fighting to get a patient to the right place and do the best for your patient, and then you come off and you're just scrolling through your Facebook, and then you get all these negative comments in the media, that's really, really demoralizing. Like, I mean, I cannot tell you how many days we've had people in tears at the way that people are speaking to our receptionists on the phone. And I think I think we all have a little bit of responsibility for how we make comments about things. Patients remember the flippant comment that you say when you're frustrated. And I think this works both ways. This is not I think this happens in the community as much as it happens in the hospitals. But those little throwaway comments that people make because they're feeling a bit frustrated about, oh, I don't know why your GP didn't do that, or, oh, why are you here, sort of thing. Patients remember that. And I think at the moment when genuinely we have a trust issue, for various reasons, but we do, I think, for some patients have a real trust issue. Those can be really more damaging than I think people realize when they're making them, because I think a lot of the time they're making it because actually they're having a bad day. But I think we all have a responsibility to just recognize that we can have a positive or negative impact with what we say. But you asked me about positive things, and I very quickly went on to negative things there, didn't I?
No, you didn't. You didn't, because you spoke. You absolutely didn't. And actually, it fits with something that I absolutely believe, which is the things that make our greatest strengths are our greatest weaknesses. So the relationships between the first positive thing you mentioned was around the interface between primary and secondary care, and many people that I've spoken to, Laura, have spoken about that kind of camaraderie, war effort type approach at the beginning of this. And so being connected, having a common goal, and that shared responsibility is absolutely a real strength. And the trust that generates, and the strength of relationships. So our greatest strength actually becomes our greatest vulnerability when that doesn't work. So I think there was quite a balance there. And you said nothing that I didn't expect to hear, actually. The individual heroic acts of different people across our system, the going above and beyond. And then you spoke earlier about the kind of little COVID team. I think many teams have gone unnoticed. And of course, I presume you and I can both empathise with the public, because the rest of the world seems to be getting back to normal, and still it's difficult, and there are significant waiting and access issues across health and care. And that's going to continue for some time. So how do we work differently with the public? And I suppose you've again moved us, you're very good at this, you've moved us into the next question, which for me is around, so what needs to be different post-COVID? And we've had a few conversations, Laura. You know that I am very interested in the reform of health and what that needs to look like. And for me, it needs to be about people, be that people working in it or people accessing the services. And I don't think my lived experience in 30 years in the NHS as a nurse is the public don't differentiate between a GP or a hospital. It's all, and we know it's not, but it's all health. And it's all, for me, therefore, it's all about pathways, and the interfaces at each bit of the pathway are really important, and primary and secondary care is one of those critical ones. So for me going forward, there's something really important around what are the, you spoke about individual relationships, and that's great if you've got them, but what if you're new and you haven't had time to build those relationships? So how does our system make that easy for people, as opposed to it feeling like a battle every day, which I'm sure if I was having a conversation with a secondary care colleague would say the same. So yeah, what from your perspective have you learned? What needs to look different? What are the opportunities coming out of this for us in Grampian?
So I think there's a way that we can be efficient with our workforce and getting the right person doing the right job, and communicating that appropriately. So we have an issue with people wanting a GP and not a nurse practitioner, and that actually that's you're seeing somebody who's probably going to spend longer on their house visit and spend more time doing this, and they are perfectly capable of looking after the issue that's at hand at that moment in time. So I think there's something about communicating who our workforce is, and supporting that for patients. So, and I work is happening for these things, because certainly that's not an NHS Grampian alone problem. But I think it is important. I think that right place, right time sort of campaign to make sure that people are accessing services. But I also think we need to be asking our patients how they find that, because I think people find it confusing. And we do have to recognize that we have Amazon Prime 24-hour grocery type mentality. Other brands are available. Sort of, but that's we need to be able to move and recognize the challenges that we have in healthcare, that society is saying, well, wait a minute, I can do this. So that, I can go to the pub. Why can I not come and see my GP for their appointment? Like it doesn't make sense. It is illogical. And I don't know that we're always very good at really getting that message out. And I think in care, partly because of the way that we've been portrayed by the media, some of the comments that have been made about things, I think we're on the defensive, and actually need to be a little bit more, this is what we're good at, this is what we do, and this is why you need to come and see us for this. And actually your accident and emergency is best dealt with by accident and emergency, but really is what you have an accident and emergency? No, it's not. It is perfectly acceptable that waits for, even 4 hours. I have people, that I've phoned working for the hub, when, they've had a 4-hour call back from, so they've spoken to somebody at 111. And I think, that it has been difficult. They've maybe waited for over an hour to get through to somebody from 111. They've then had a call back from somebody, and then they're told it's going to be 4 hours. Now, it's perfectly, from a healthcare point of view, acceptable that they wait that long. Their problem is not likely to get worse in that time. And whilst it may be 6 hours from the point that they've decided they need to speak to somebody phoning them back, actually, when you're the one that's waiting for the phone call, 6 hours is quite a long time. Yeah. And you're probably scrolling on Google and you're discovering all the myriad of things that are probably wrong with you. And so you can then sort of, I can start to see why the thought process then goes, well, nobody's phoning me back, go to A&E. So I think there's work in that sort of messaging about things. I mean, the whole let's return to face-to-face consultations is fascinating, because the reality is if we did that and we went back, we'd be back to having a 3-week wait for a routine appointment, if not longer. And I think people have forgotten that it wasn't working before COVID hit. So, we had to introduce all these COVID measures in order to keep our waiting areas safe, and our staff safe, and patients safe, vulnerable patients able to come down to the surgery. Actually, it wasn't really working before. So this whole let's return to normal, I would be on the same mind as yourself. I think is that actually normal, if it's what it was before, was broken. So
Yeah.
So actually I don't want to go back to that, because actually it wasn't great. I love having a bit longer with patients, so we allow our appointments to be longer. And so, a phone call might not take as long, but a face-to-face we allow. We've moved away from 10-minute consulting, certainly. And I think, that's time well invested. That from a patient and doctor relationship point of view, that's been time well invested. I've used video a lot in unscheduled care. So with the COVID hub GMed, video seems to work really well. It hasn't embedded quite so well into daytime practice. And I suspect, is that partly our patient population? Is that partly our sort of mentality as a practice? Equally, folk are just around the corner. So I think it doesn't, it works better when I'm, I need to speak to somebody in Tom and Tool. I'm not going to just bring them down to the practice. So there are ways that I think it probably has worked. I suspect from a hospital point of view, some of the video things have been absolutely fine.
Mm-hmm.
But we're working with changing attitudes, and that takes time. And I think COVID has made us do that all overnight. And now people are going, well, wait a minute, what's happened? And I think it's how we communicate why we're doing things with people is really important. And that's probably something that I suspect, because we've been a bit defensive, it's always been a reaction to something rather than a proactive, actually, we think this is going to be good. And I also don't think it's going to be a one or other scenario. So I don't think it's going to be everything should be done by telephone, everything should be done by face-to-face, everything should be done by video. I think that's just a pendulum swinging. I think the reality is we want to find that sweet spot in the middle. That doesn't happen overnight either, does it?
No, definitely not. However, I mean, what you've said absolutely resonates, and it's about how do we. So for me, it's about how we together as independent practitioners, as health, as social care, how do we work with the public in a very different way, and part of that is around managing expectations potentially of very different generations, I think, and not do blanket, this is how we're going to do it. It's actually, what is it that we need to do to best suit this individual? And you, like I, will have heard really positive experiences of virtual consultations and how that's enabled carers to be part of those conversations, people not having to leave their homes, etc. But then also there's a big thing, and I do wonder if it's a generational thing. I have no evidence around that other than the dynamics that go on in my family, about being able to build trust virtually. And you've spoken about trust in teams, but actually trust between patients, families and their clinician, which for me is a key function of general practice, and the primary care team is really important. And that's changed over the years, hasn't it? The ability, I mean, I'm sure when I was little, you had a named GP, I think. You had a named, and that's all. So we do have to move on. And I think the important thing that I'm hearing from you is we have to move on and work with people that use our services to shape that. And I couldn't agree more strongly that the system we had previously was just not sustainable, just for any of us. And whilst individual interactions in the main were caring, and were fantastic, the system as a whole was not efficient, and waiting 3 weeks to see somebody. Whilst, I really like the way, Laura, that you acknowledged, from a healthcare professional that has undergone significant training and education, absolutely, the notes that you have in front of you to say you need to call somebody back within 4 to 6 hours, you're really comfortable with that. But for somebody that has no healthcare background, that's really frightened and worried, the level of anxiety that wait provokes is horrible. So how do we manage that differently? Some really, really good insights. And the bit for me is, and we'll follow this up after this conversation, is so how do we do that? How do we do that together? And I know there's the interface group, I think, between primary and secondary care, and other opportunities, but also We have Stuart Reary now as part of our systems leadership group. So that's bringing general practice in, but really keen to take that forward. I could speak forever, Laura, but I can't. So I think you've touched on some of these things, but really keen to hear just finally on what makes a good day for you. You've spoken about the banter, the camaraderie, but what makes a good day for you as Laura?
So this is other than a day of annual leave, presumably.
Although that'd be nice.
Yeah, yeah. So a good day for me is a day, I mean, as a GP, you have a certain amount of unexpected workloads. That's absolutely fine, because you never know what's coming in the door, other than what's potentially been taken as a note. So that was always a draw for me for general practice. So, but actually some control over my workload would be nice. So I don't mind, the unexpected emergencies. That's just part and parcel of what we do. But the uncontrollable workloads that we have just now. So a good day for me is a day where I manage to actually get up and have a cup of tea and have some chat with people. I mean, an amazing day is where I manage lunch away from work. So that's, as in away from the desk. So that's, you're on a really good day when you're managing that. And then, to be honest, just getting home on time. So it's it's those sorts of things. And I'd love to be able to say that, and then fit in a run, and then do all these sorts of things. But yeah,
we won't talk about that waistline again. Let's not go there.
That's like this. That's an aim for the future now. But I mean, joking aside, actually, it's just that. Yeah, it's, I mean, obviously want to make sure that I've made good decisions for my patients, clearly, and had good interactions. I mean, I didn't really go into general practice because I wanted to be a call center GP. So, I like the face-to-face contact. And I think that's what's been really fascinating about this whole discussion in terms of face-to-face, is that, like, we're not loving it. It's not really, ideal for us either. But a day where I've had a chance just to catch my breath, and a workload that hasn't escalated exponentially by 9 o'clock in the morning is generally a good day.
Brilliant. Yeah, and gosh, we're human, and humans thrive on social interaction. So that's not a surprise. And actually, control is a really important thing. It doesn't matter what job. If you feel that you are not in control of how you are running your day, then and I've had so many conversations with colleagues that feel that it is not within their gift to control their working environment, yet they remain responsible for it, and that makes it really hard. Laura, it has been an absolute pleasure. It's felt like blathering to you, actually. It's been an absolute pleasure. I'm looking forward to meeting with the team, and we've arranged to do that. And I would just like to thank you, and to convey my thanks to all primary care teams, which obviously is inclusive of GPs, and to acknowledge that the massive effort and changes that you guys have had to go through, the importance of the roles that you fulfil. And actually, just to call out, it doesn't matter how frustrated people are, treating people disrespectfully is just not something that I believe we can tolerate. And acknowledging what's sitting underneath some of that anxiety and that behaviour, as you've discussed so eloquently, I think is really important. So huge thanks to the heroes of primary care. Laura, I hope you managed to get a cup of tea, get your lunch, and be in some level of control today. And I'll speak to you soon.